All right, we are finally on the endocrine system. This will be our last system. And the endocrine system is going to involve glands that release hormones. And a hormone is a chemical messenger that gets released into the blood and travels to a distant site. And so all of the glands that are involved in the endocrine system, starting at the top, pineal, hypothalamus, pituitary, thyroid, thymus, adrenal, pancreas, and then the gonads, ovaries, and testes. And we'll talk about some of those in detail. And then here's another view, the major endocrine glands that I just mentioned here on the left. And then organs that contain some endocrine cells, meaning that they have some cells that are going to release hormones that travel to a distant site. Although we are going to just focus on the glands that are on the left. And so I mentioned before when we talked about the nervous system that you have this master regulator for the endocrine system, and that's the hypothalamus. So remember, there's a long list of stuff that the hypothalamus did, but for this body system, we're only going to focus on what it does for the actual endocrine system. So it is considered like a master gland that is going to receive information from the brains, from nerves in the brain. So nerves in the brain are going to signal the hypothalamus to do something. It's going to send a signal to a gland to release a hormone. And so it's going to initiate endocrine signals. The first place that it signals is the pituitary. So this is like your master regulator of the brain, and then it first signals the pituitary. Then the pituitary is going to send signals to glands in the body to release hormones to achieve, maintain some sort of homeostasis. Right, so right here it shows you just another picture of the brain and where the hypothalamus is located, and then the pituitary is underneath. So the hypothalamus signals the pituitary gland, and the pituitary gland consists of a posterior pituitary and an anterior pituitary. So there's two lobes. And so each one of those is going to do something specific. Right? So like I said, the hypothalamus is going to receive information from the brain, and it's going to send signals to the pituitary gland. And so a couple of examples of what each part of the pituitary gland involves. The posterior pituitary is going to release a chemical called oxytocin. Oxytocin is the hormone that's involved in bond formation. Oxytocin is considered the love hormone. So when someone gets attached or creates a bond, and it doesn't even have to be like a romantic bond. I mean, this would be like bond between mother and child, bond between friends. It's believed that oxytocin is the hormone that is released whenever those feelings occur. Oxytocin is also involved in breastfeeding and helps with the ejection of milk. All right, antidiuretic hormone is released, and sorry, I should have taken that out and I should have put a parenthesis, whatever. Antidiuretic hormones released from the posterior pituitary. Antidiuretic hormone is going to increase blood pressure. And you're like, oh, increased blood pressure, that's bad. Well, no, not necessarily. You want your blood pressure to increase whenever your organs are needing extra oxygen. It's when blood pressure is at a chronically high level that creates problems and can contribute to cardiovascular disease. But antidiuretic hormone in itself is not such a bad thing. The way that I try to help students remember ADH or antidiuretic hormone is if someone's in a car accident and they're bleeding and they're hemorrhaging, they're losing blood. And if you lose blood from your blood vessels, your organs are not getting enough blood. They're not getting enough oxygen. So that is a situation where you would want antidiuretic hormone to kick in and to keep the kidneys from taking water from the blood, to keep the water in the blood, keep blood pressure high so that blood can still reach the organs and deliver oxygen until some sort of medical intervention is made and the person stops bleeding. All right, the anterior pituitary gland is going to, an example of something that it releases is FSH. FSH is follicle stimulating hormone, and it is going to stimulate the production of egg and sperm in a woman and a man, sorry, egg and sperm in a man or a woman. We mostly hear about FSH in women though, because the levels fluctuate in women, because you know that a woman will only ovulate once a month, or once every 28 days, typically on average. But in men, FSH is going to be at a consistent level because they're just producing sperm all the time and they don't have like a cycle like we do, or like women do, sorry. Luteinizing hormone, LH, is what is going to stimulate ovaries and testes. And LH, you're mostly going to hear about that because there's an LH surge right before a female ovulates. And so this is kind of interesting because a female who is trying to get pregnant can buy a kit at the store. And it's like this little meter. It's almost kind of like a blood glucose meter. So there's a machine and then there's little test strips. And so what she will do is she will urinate on a test strip every morning, stick it into the machine, and it'll tell her what her luteinizing hormone levels are. And so LH is going to surge probably around day 12 or 13 of a woman's cycle. And then she'll ovulate, actually like spit out the egg out of the ovary on day 14. But there's going to be an LH surge right before that. And so this monitor, this machine, will tell her when there's a surge of LH in her urine. And a lot of women who do have trouble getting pregnant can use a kit like that or a monitor like that to help them know when they're about to ovulate. All right, this is a very extensive list of all of the glands, all of the hormones. And I am going to just focus on a few of these. I'm going to focus on, I already talked about oxytocin, and antidiuretic hormone, but those are on the next page again. So sorry, I got a little ahead of myself. But these are just all the glands, all of the hormones. This will just tell you, is it a protein or does it have a carbohydrate hanging off of it? Where does it work and what does it do and what regulates it? Same thing with this next one. Adrenal glands, pancreas, gonads, and the pineal gland. I already talked about the pineal gland and melatonin, so I don't think I talk about it again. I know I made these notes myself, but I made them a couple of weeks ago, so we will find out. So I'm going to move on from that. So the hypothalamus, once again, is going to stimulate the posterior and anterior pituitary, and I already talked about this. And I talked about ADH already, antidiuretic hormone that is released. Antidiuretic hormone is going to make sure that the kidneys are not taking water from the blood, so it's going to increase blood pressure at times where blood pressure needs to be increased. Oxytocin is going to stimulate the uterus, and it can actually stimulate contractions in the uterus. That helps with labor, but it also helps with breastfeeding. And then remember, the oxytocin is going to be your bond formation. And so I always tell this story when I give an endocrine lecture, so I'll tell this story. So I worked at this pharmacy once. It was a compounding pharmacy. So a couple of you probably already heard this story if you actually watched that lecture. So we'll see. Actually, I won't ask you about it. But if you didn't watch the endocrine lecture while we were at distance learning fourth quarter, here you go. Here's the story. I worked at this compounding pharmacy where we actually we didn't make the drugs. The drugs came to us in like a pure form, and we made the delivery or the vehicle for the drug. So we would get a pure drug powder, and then we would make capsules, tablets, injections, suspensions, stuff like that. So we had got an order of pure oxytocin in, and this was kind of a weird pharmacy. It was a little shady, which is why I didn't stay at that particular place. But while I was there, I did notice they were making these candies, and they were these little red candies, and they're oxytocin candies. And so they were marketing them, and they were selling them to people as the fall in love drug or something like that. And you didn't actually like need a legit prescription to get it. So they handed me like a box of them, and I took them home. And so you were supposed to take them, the directions were to take them 30 minutes to an hour before like going on a date or something. And so I tried them, and they actually didn't work. They don't work. And so I think that brings up a really good discussion though for this class is, why doesn't it work just to eat a hormone? Well, a hormone is going to usually be a protein. And if you eat a protein, well, oxytocin is used to functioning at a pH of 7.35 in the blood, right? But if you eat oxytocin, your stomach is at a pH of like 2 or 3. a really, really low pH. So oxytocin gets degraded in the stomach before it can ever reach the bloodstream. So that's why some things you can't take them in tablet form because the stomach will degrade them. Anyway, that's my fun story about oxytocin. Um, Obviously, I no longer work at that pharmacy, and I think they ended up getting shut down for some other weird stuff that they did. But I did not contribute to any of that. I left before any of that. But that is one story I get to take away from that place. So I'm thankful for that. And so oxytocin is also going to stimulate mammary glands in the breasts and help with breastfeeding. And so that's part of the reason why when a woman breastfeeds, she creates what some say to be a stronger bond with the baby because she breastfed. I'm not sure just how true that is, how it carries through the rest of life, but apparently that does help with bond formation. All right, so the posterior pituitary, like I said, releases the ADH and the oxytocin, and this is just kind of showing you how it does it. It has blood vessels, and then it releases the hormone, and the hormone goes into the blood vessels, as you would assume. All right, and I already talked about oxytocin. Let's see if there's anything here. Maybe used to stop postpartum bleeding. Well, no one really wants to talk about that, so I won't focus on that. Contractions in the uterus, milk ejection, and then possible trust me hormone. It produces positive feelings towards others. So while women will typically have a higher level of oxytocin than men, men still do have oxytocin. And it has been said, now I don't have the research on hand to back it up, but I just want to tell you something interesting because I'll throw things like this out in class. And I would hope that a student would maybe fact check me, but I've heard men with lower levels of oxytocin have a more difficult time being faithful in a relationship. That's what I've heard. And probably the same goes with women, but the study that I'm referring to actually tested men and their oxytocin levels. Does correlation always equal causation? No. But I thought it was kind of an interesting study because they will find in other mammals, the higher the level of oxytocin, the more likely they'll form what's called a bond pair, which means that, and the naked mole rat will do this. A bond pair means that the naked mole rats are committed to one of the opposite sex, and they're committed for life. And the higher the oxytocin levels, the more likely those mole rats will be able to stick with that partner for the rest of their lives. So something interesting to think about. All right, and then I've already talked about ADH, but now you have some visuals to go with it. So just to recap that, ADH is what's released when water levels are low. So even when a person, so I mentioned that this would be a person who's gotten into like a car accident that might be hemorrhaging or bleeding out. But this also could be a person who's very dehydrated. So I can't remember the name of the movie. Dang it. I think it was called 27 Hours, 47 Hours. You'll remember it when I say it, I think. It's the guy that was hiking and he got stuck. He got stuck. And he ended up like sawing his own arm off. Yes, because he came to St. Mary's Hall. This is the guy that the movie was made off of, came and spoke at St. Mary's Hall. Now, I did not work at St. Mary's Hall at that time, so I didn't see it. So now, yes, everyone knows who I'm talking about. You should. You might not have been in upper school at that time, but you probably heard about the guy. So the 27 Hours, I don't even know. I just know it was James Franco. That's all I really remember. And so he was stuck in that situation. He ran out of water. He was even drinking his own urine, but that's an example of severe dehydration. So in a situation like that, while as extreme as it is, that's a situation where you would definitely want antidiuretic hormone to be released because the word diuretic comes from the word diuresis, which means to urinate and to pull water out of the bloodstream. So antidiuretic hormone is going to stop the kidneys, at least stop them to a certain extent. Could you urinate yourself to death? Yes, you could. If he would have gone long enough, had he not cut his arm off, his antidiuretic hormone wouldn't have been able to save him, but it did help him for a certain period of time. And so the kidneys will reabsorb, meaning water will come through, but then the kidney will be like, nope, you got to go back, and we'll put it back into the bloodstream. All right. And so that's what antidiuretic hormone is going to do. And this just shows you visual for it. Water content of the blood is normal. Too much salt or sweating or not drinking enough water, water content's low. The brain produces ADH. ADH makes the kidney not take a bunch of water. Urine output is low. Then it can go to the opposite. Too much water is drunk. The brain produces less ADH because there's too much water in the blood. Blood pressure is getting too high. And so the urine output will be high to get rid of that water. There are blood pressure medications that will actually block ADH and will cause a person to urinate more. So knowing about ADH can actually treat high blood pressure. So large amounts of ADH is going to cause vasoconstriction, which increases blood pressure. Alcohol inhibits ADH. That's something kind of interesting. So this is why when a person drinks, they're going to urinate a lot. And you're thinking to yourself, well, I'm urinating a lot just because I'm drinking a lot. But then if you really think about it, you're like, no, I'm not drinking enough to be urinating this much. Why am I urinating so much? This is why. Because alcohol will inhibit ADH. Remember, ADH decreases urination, increases blood pressure. And so alcohol increases urination, causes dehydration. So when a person gets sick the day after drinking alcohol, has a hangover, that is what's caused the excessive dehydration, is the inhibition of ADH. And so that is why a person will need to take a lot of electrolytes and drink a lot of water the next day. It's just a big mess. So just another reason to never drink alcohol. I mean, seriously, like, look at what it's doing. So just don't do it. But in case you're wondering, that is why it makes a person urinate so much. That is why it causes intense dehydration the next day. All right. Other hormones of the anterior pituitary, or hormones of the anterior pituitary, involve growth hormone, which causes bone and muscle growth. Prolactin, which is another hormone that's going to stimulate milk production in the breast. Follicle stimulating hormone, luteinizing hormone, like I said before, I'm just kind of recapping over hormones that I've already mentioned, are going to stimulate the ovaries and the testes to produce egg and sperm. Thyrotropic hormones, TSH, thyroid stimulating hormones, which are going to cause the release of T3 and T4 from thyroid. And I'm going to talk about the thyroid in just a minute. The anterior pituitary is also going to release what's called adrenocorticotropic hormone, ACTH, which is going to stimulate the adrenal cortex, which is going to be involved in adrenaline release. And so I would like to talk a little bit about some disorders. So I talked about the hypothalamus. I talk about the posterior pituitary and some of its hormones. And now we're talking about the anterior pituitary and some of its hormones. Now I want to get into, when we talked about oxytocin, ADH, now I'd like to get into some disorders, all right, after each one. So pituitary dwarfism, this is something kind of interesting. So I mentioned growth hormone. Growth hormone causes the growth of bones and muscles. So if someone has hyposecretion, anytime you see hypo in anatomy or in medicine, that means less than what it should be. Hyper means more than what it should be. So hyposecretion means less secretion of growth hormone during childhood. They have fairly normal body proportions. Proportionally speaking, it looks normal, but the maximum height is going to be 4 feet. So that's something kind of interesting. On the opposite end of this spectrum, hypersecretion. And so these would be genetic disorders. Hypersecretion of growth hormone during childhood can cause an adult to reach normal proportions, but they'll reach a height of 8 to 9 feet. Pretty, and that's called gigantism. So pretty interesting. All right, the thyroid gland is found at the base of the throat. It's like a butterfly-shaped gland, and it produces 2 hormones, thyroxine, T3, and T4. So it's going to release the thyroxine hormone. So when it's T3 and T4, they're just both thyroid hormones. All right. Thyroxine is a major, so you have thyroxine right here, which is T4, and then triiodothyronine, which is T3. So where it says 2 hormones, I accidentally left that second one. So thyroid hormone, thyroxine, which is T4, and then triiodothyronine, which is T3. Okay, so the pituitary gland is going to release thyroid stimulating hormone. Thyroid stimulating hormone from the pituitary travels to the thyroid and then is going to activate the thyroid to release T3 and T4. Okay, so now that we got that straight, T3 and T4, thyroxine and triiodothyronine, are major metabolic hormones that readily cross the plasma membrane. They are going to target every body in the cell. They're going to increase the rate of ATP production. They're going to increase the rate of oxygen consumption, and they're going to generate body heat. Okay? So what happens when the thyroid is underactive? Hypo. What happens when it's overactive? Hyper. So if you think about what they do, metabolic, body heat. All right. So if someone is hyperthyroid, something that you could definitely already anticipate would be weight loss, and I don't know if heat intolerance. So that's something that you can already assume based on the description I said in the previous slide. So the other things, bulging eyes are a pretty telltale sign that someone's suffering from hyperthyroid. Weight loss, sleep difficulties, because if you're like overactive making ATP, they're going to have really bad irritability, anxiety, insomnia. All right, and then it's going to mess with fertility, because there's a really delicate balance between all of the hormones. So it's kind of a domino effect on the sex hormones too. Nervousness, and messed up menstrual cycle. On the opposite end of the spectrum, hypothyroid, what you can expect would be weight gain and cold intolerance. Also depression. So if hyperthyroid leads to anxiety and irritability, on the opposite end of the spectrum with hypothyroid, you're going to have a lot of depression. And so typically hypothyroid, just from my own experience working in clinicals, hypothyroid is going to be more prevalent than hyper, and you're going to see it more often in women. Mostly women in their 40s and 50s are going to need to be regularly screened for hypothyroidism. I think it just has something to do with a domino effect of when women's sex hormones are starting to get lower and lower. All right. And then I just want to say one thing about how do you treat this before I move on. So hypothyroid, not making enough thyroid hormone, all you do is supplement. And what's really cool about T3 and T4 and thyroxine, you can just eat them and they pass right into your bloodstream, and it's a really very easy thing to treat. So you have no injections. So this is the type of hormone you can just eat. Hyperthyroidism, what they have to do is they have to actually eradicate or irradiate the thyroid, basically just zap the thyroid, kill it off. So if you have someone with hyperthyroid, you zap their thyroid, kill it off, then they enter into a state of hypothyroid, so you treat them with the same drug. All right, that is how those get treated. Okay, the pancreas. The pancreas is going to regulate glucose levels. All right, so obviously the pancreas is then going to be involved in diabetes. So two hormones that are released from the pancreas, and they do opposite things. Insulin is going to target all cells and is going to allow glucose to enter into the cell. It can cause a hypoglycemic effect, because if insulin is causing glucose from the blood to enter into the cells, then glucose in the blood gets low, it stimulates you to eat. Glucagon is going to do the opposite. Glucagon is going to sense when a person does not have enough glucose. It's going to target the liver where glucagon is stored, and it's going to cause the breakdown of glycogen. Glucagon is the hormone that gets released that targets the glycogen in the liver cells, causes it to be chopped up, and then glucose enters into the bloodstream. It can cause a hyperglycemic effect, causing too much glucose. Okay, so here's the homeostasis of it all. Normal blood glucose levels are 70 to 110. So this isn't right after a meal. This is like many, like 4 hours after a meal. 70 to 110. So this is what a person is testing for when they use the lancet and they make themselves bleed, and then they do the test strip, and then they stick it into a machine and it tells them where they're at. Your body is normally, no matter what you're doing, if you're a healthy individual without diabetes, your body's going to always be able to maintain this blood glucose level. So let's take the two different scenarios. All right, let's say I get really, really hungry and I just don't care anymore, and I go and I get like a bunch of chocolate cake from HEB and I stuff my face with chocolate cake. All right, my blood glucose levels are going to rise. My pancreas is then stimulated. She's eating chocolate cake again. Release the insulin. Insulin gets released. She has eaten, I'm talking about myself, too much glucose. So there's not enough cells in the body to take up all the glucose from all the chocolate cake I've just eaten. So insulin is going to have the cells take up the glucose that they can, and then anything that's left over is going to be stored in the liver as glycogen for later use, for emergency use. All right? And then the blood glucose levels decline. All right, let's take the other scenario. The other scenario is I've eaten way too much chocolate cake and I'm just feeling bad about myself, and it's quarantine and I've been gaining weight. I am going to go on the keto diet. All right, and I'm going to go cold turkey, man. Less than 30 grams of carbs a day, less than 30. So I'm on the keto diet 24 hours and my body starts to freak out. My blood glucose levels get low. My pancreas is then like, oh God, she's on the keto diet again, release the glucagon. Glucagon gets released. Glucagon is going to release the glycogen that was stored in the liver and is then going to raise blood glucose levels. The problem is around 72 hours of eating no carbohydrates, your liver runs out of glycogen. So that's when it gets real tough and you get what's called the keto flu. After that, though, after like a week or so, you get better and it gets easier, I guess. So that is how the body's going to maintain blood glucose levels. So when a person has diabetes, type 1 diabetes is considered an insulin deficiency. This is the type of diabetes that's going to affect children. It's an autoimmune disease where the immune system is going to attack the pancreas and is going to basically kill the cells of the pancreas that are going to release insulin. All right. So if a person doesn't have insulin, they're not going to be able to do this right here. So what's going to happen? Eat chocolate cake and then blood glucose levels get higher and higher and higher. What is the problem with having too much glucose in the blood? Is that they clog up the microscopic capillaries. And if capillaries get clogged up, then there's parts of the body that are not going to get oxygen. And that is why people with diabetes lose limbs and have to get amputations sometimes, is because the capillaries are clogged up with sugar. Blood and oxygen can't get to that body part. It's going to what's called necrose, and that means that ATP isn't getting made, oxygen's not getting to that tissue, and it undergoes necrosis, which means tissue death, and then it will have to be amputated. So if a person is not releasing insulin because the immune system has killed that part of the pancreas, they are going to be very, very sick. And so this is a lot less common than type 2 because it is an autoimmune disease, and there's really nothing that this person can do to prevent it. That's what also makes it different than type 2. They have a genetic predisposition, which means they have a genetic mutation. It can also be a viral infection that causes their immune system to go out of whack, and an autoimmune disorder. So and this is actually one that's really easy treated. If they have a pancreas that's not making insulin, then they just inject insulin. Now, that's not so easy because they have to have a really tight control over what they're eating, have to constantly test, but it's not like their cells are like, I'm not going to use that insulin, sorry. You can just keep injecting it, but I'm not going to use it. Like in type 2 diabetes, their cells welcome that insulin, they use it. And so this one's a lot easier to manage than type 2, although it is a very, very difficult disease to have. The cardinal signs of diabetes are, and then I talk about type 2 in just a second. The cardinal signs of diabetes, and I've talked about this, is excessive urination because of all the glucose in the blood. And remember, water likes to follow solute. So it'll get, and then I told you that the way that they used to diagnose this was to taste the urine. So the glucose is going to be spilled into the urine, water is going to fall, so the person's going to be very dehydrated and thirsty. So these two go together. Excessive urination is going to lead to thirst. And then polyphagia, so polyuria is excessive urination, polydipsia is excessive thirst. Polyphagia is excessive hunger, because if you're eating a bunch of glucose, which we are programmed to go to first, we just are. That's why they put bread on your table when you first go to a restaurant, because if you are hangry, bread is going to fix that hanger quicker than like a slab of meat. So we are programmed in it, and it causes a release of dopamine too. So we're programmed to go for the carbs first. And so a person with diabetes will keep eating more carbs, more carbs, more carbs. Their cells will be unable to take them up. And so this person will be constantly hungry. And they will actually go into a state of ketoacidosis, which is kind of like what the keto diet does, except it's actually really dangerous because it causes the blood to become really acidic. All right, type 2 diabetes is similar to type 1 in that cells are not getting glucose inside of them, but it's not that the person isn't producing insulin, it's that their cells are saying no more. You've eaten too many Cheetos, you've drank too much Coke, you've been unhealthy for too long. We are no longer going to open the door when insulin knocks. That's kind of what the cells are saying. Things have just gotten too bad, so cells are ignoring insulin. So that makes it a little bit more difficult. You can't just inject a person with type 2 diabetes with insulin and expect for their cells to use it. So what a person with type 2 diabetes is then going to do is they're going to take drugs that are going to unlock the cell to take up glucose, that is going to make the cell more sensitive to glucose. And so you will have some people that take a drug that makes them more sensitive to insulin, and then they're going to also inject insulin. So a type 2 diabetic will take insulin, but it's not the only thing that they would take. They would take a drug that makes them more sensitive to insulin at the same time. And so type 2 diabetes in the United States is occurring at younger and younger ages, and I don't really think that I have to explain to you why. It has to do with our diet, and I know nobody wants to hear that, Typically, those students at St. Mary's Hall usually eat healthy enough. And a lot of this does have to do with socioeconomic status. The higher the socioeconomic status, it seems like the healthier a person does eat. And that's been proven. I can show you research on that. The lower the socioeconomic status, the worse the diet, and the more likely a person is going to end up with diabetes. And this is part of the reason why they're saying coronavirus has really affected a certain socioeconomic status person, a certain demographic, worse than it has the others, and they think that the likelihood of people having diabetes, the underlying conditions, I've seen diabetes as being the most common underlying condition that causes complications with coronavirus. So what do we do? I think that, and we could get into a big discussion about this. I think that the government taking more control over what foods are served in public schools. You should see at the public school that I worked at before coming to St. Mary's Hall, it was just horrible what they served to those kids in the lunchroom, just awful. And just more education. So I'll get off my soapbox on that, and I'll start talking about the pineal gland. The pineal gland is going to regulate the sleep-wake cycle, and I know I've already talked about this a little bit, but I just want to point out a few things. This lecture, since it is the last lecture, and since endocrine system is so important for so many different diseases, I am going to just do it till the very end. I'm not going to rush this. Sorry, my kids are screaming downstairs though, so maybe I should rush it. So we have melatonin, which regulates the sleep-wake cycle. When it starts getting dark, your pineal gland will start releasing it, and that's what helps you sleep. And when it starts getting dark, you can take a melatonin gummy or a melatonin chew, or I've even had some melatonin spray that I spray in my mouth, and it works real good. And I take it every night, and I haven't had any problems. I have heard, though, that there is a correlation between exacerbation of depression symptoms in a person taking melatonin. So if you are prone to depression, or you are struggling with depression, trying to get depression under control, taking melatonin actually can make that worse. Obviously not everyone, but there are studies out there that there is a correlation. So the production, like I said, is affected by visual cues like sunlight, so when it starts getting dark. Levels decline at puberty. So this is kind of interesting. This is why when a person hits puberty, they end up not being affected by it being dark outside, and that's why a person in their teen years end up staying up later. So I think that's really interesting. So it declines a little at puberty. So it goes up, 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 up. So little kids sleeping a lot. They get so tired, they just like pass out in their high chairs. And then all of a sudden at puberty, it's going to start declining. And so I think this, like I said, this is why I think teens start staying up later. But then you're like, wait, my mom and dad are like in their 50s and they go to bed at 8. That doesn't have to do with melatonin. That just has to do with the exhaustion of having kids and working. So melatonin actually starts declining drastically after puberty, and then especially in older adults and senior citizens, it's going to be at a really low level. So insomnia, exhaustion increases as you get older, but insomnia becomes worse, and therefore it's like a downward spiral. Exhaustion becomes even worse. So getting old is unfortunate, but we have the gummies at CVS, so just go buy some of those. I think this is also really interesting, seasonal affective disorder, also called SAD. Coincidentally, it's called SAD. It's an increased melatonin production in the winter that causes a person to sleep more, but then they're also going to have some atypical changes in their mood, which is going to lead to depression, lethargy, changing in eating habits, weight gains, changes in sleeping patterns, and it's usually common in high altitudes that are lacking sunlight for long periods of time. So I don't have seasonal affective disorder. I know I give you all personal stories, but I think that's a good way to teach. I'm telling you like what I've actually experienced. I don't have this. I've never been diagnosed with it, but I do know that my mood is a lot worse, and I have to be real careful in the winter months to not get too low. And so exercise, for me, exercise and making sure I go outside when it is sunny is really important. This is something that also affects people who have who work overnight. I used to work in a pharmacy overnight. It was actually a really cool pharmacy. We had vending machines that we put in long-term care facilities. So they would send me an order for something, and I would just click a button. And so I was at a remote pharmacy, and they were at the long-term care facility with the vending machine, like drug machine. So a nurse would type something in, kind of like you would like a soda machine. It would send a message to me like, hey, they want their hydrocodone. This was back when hydrocodone was like as tightly regulated. And I'd be like, sure. And I'd push a button. Obviously there was a prescription backing it up, but I would have the hydrocodone drop, and the nurse would take it and give it to the patient. It was super cool. Anyways, it was an overnight job. And so I had to actually get a lamp. There was like a UV lamp, and I had to like put the lamp right next to my head because sleeping during the day and being up all night had such a bad effect on me. And unfortunately, even the lamp didn't work. I just couldn't do that. And I really admire and respect people that can work overnight, but I just couldn't do it. Okay, ovaries. All right, the ovarian hormones, estrogens, and so estrogens are going to target most cells. It's going to be responsible for the female secondary sex characteristics and reproductive organs. It's going to be involved in follicle maturation, which has to do with the follicle is what's around the egg, and follicle will mature, and then the egg will pop out of it once a month, and estrogen is going to be responsible for that. Estrogens also go up during pregnancy and are going to help maintain pregnancy. All right, progestins. Progestins are going to target the uterus and the mammary glands. Progesterone is going to be the primary progestin. It's going to produce the corpus luteum. The corpus luteum is like a clump of cells that will form during pregnancy. So this is kind of interesting. Progesterone is going to cause this clump of cells to form in the ovaries during pregnancy, but then the corpus luteum itself is going to release more progesterone. progesterone is a very, very important hormone to maintain pregnancy, to keep that embryo, fetus, and then eventually the baby in there with enough, blood lining and nutrition and stuff like that. Progesterone is very important for making sure that a pregnancy is maintained. So women who are prone to not being able to carry pregnancies to full term, or they're prone to early miscarriages. I guess any miscarriage would be an early miscarriage, but they're prone to pregnancy loss. It could have something to do with having too low progesterone levels. So something that they can do is before getting pregnant, they would want to take a lot of hormone therapy and take progesterone. All right, so it maintains pregnancy. Progesterone, since it maintains pregnancy, it's also used, there's progesterone birth control pills. So a woman can take progesterone as at a certain dose to trick the body into thinking it's already pregnant, and therefore she won't ovulate and she won't get pregnant. And that's the same thing with estrogens too. So a lot of time your birth control pills will be a combination of estrogen and progesterone, or it could be one or the other, and it's going to make the body, the ovaries, think that you're already pregnant so that they won't release any more eggs, and so a person wouldn't get pregnant. Progesterones also prepare the mammary glands for milk production, and they regulate the menstrual cycle. Okay, hormones of the testes. Now, estrogen and testosterone are in both sexes, but I'm just mentioning estrogen for female and testosterone for male because those are the two sexes where they have the most. So the testosterone is the most important for the male secondary sex characteristics, behavior, and the reproduction system. It's responsible for sperm cell production, and it's responsible for protein synthesis in skeletal muscles. Now, I want you to remember this when you do your assignment today. The more testosterone a person has, the more protein is made in their skeletal muscles, the more muscly they are, the more muscular they are, and the more advantage they will have when it comes to athletics. Remember that. Testosterone is going to decline by age. So men in their 50s, and I saw a lot of men in their 50s coming in for things that are a result of having low testosterone. Yeah, I won't mention all of those things, but I would if I was in the classroom, but for some reason, like some of the topics that I normally talk about in class, I don't feel as comfortable like talking about in a recording and having them played in your home. Not that they're inappropriate, but they just need to be in a classroom setting. So a man will come in and he'll have what's called low T. He'll be diagnosed with low testosterone, and so I will dispense him a bottle of something called androgel, and it's just this pump, and he pumps this gel into his hand, and he is going to rub it on the inside of his wrists or his groin area, and he's probably going to rotate or alternate sites, and then it just diffuses across, because we know that testosterone is a lipid hormone, and it just diffuses into the cells and it diffuses into the bloodstream, and so androgel is extremely expensive though. And you have to be like really, really careful with prescribing it, because you can imagine if testosterone increases skeletal muscle mass and increases athletic performance, there are doctors, just like there's anyone who is not doing what is ethical and what is right in any profession. They're usually the minority, meaning it's usually a small percentage of practitioners that are going to do this, but I have so many pharmacy stories, and this is why I don't work in pharmacy as my main occupation, because there's too much shady stuff that I saw going on, and I just didn't feel right about it. I never did anything like illegal or anything, but I saw some things that made me uncomfortable. And that's what I love about teaching, is that I can tell you guys about these things, and then you go on and you go to medical school and stuff like that, and hopefully you won't do some of these things. But at one place I worked at, actually here in San Antonio, there were doctors that would see athletes and bodybuilders, and they would send them into our pharmacy to get testosterone injections and androgel. And so, of course, I would submit these prescriptions to the DEA, and the DEA, if they had an issue, I was just kind of the middleman. I was like, all right, I mean, if this is a legal prescription, I am submitting this prescription to the DEA. They are going to check it out. And so as long as you've got all your boxes checked, I'm going to go ahead and dispense this. But it was so obvious that it was obvious that these were men that really weren't suffering from low T. They just wanted to be bodybuilders. All right. I made it to right at 45 minutes. I hope you enjoyed some of these topics. This is the last lecture, but I do think endocrine is the most interesting besides nervous system. Nervous system is my top choice. Integumentary, I think, is the easiest choice, but I definitely would say endocrine is one of my very, very top just because I find the disease states like diabetes and hypothyroid and stuff to be very interesting. Your assignment today is on sex determination and how a person is determined to be eligible to compete in female athletics. And it is a controversial topic, and I really am excited about this assignment. I've never assigned this one before, but I'm really excited about you guys doing this and hearing your feedback on it. And I will talk about it a little bit more in the Zoom. So thank you for listening, and thanks for listening to all of my lectures. Hopefully you listened to all of them and you enjoyed all of them and you feel like you've learned something from this. I will talk to you guys later.